When we started looking at palliative care as a human rights issue, what really struck me when interviewing patients who had been suffering from severe pain due to cancer or other illnesses without getting access to treatment, their testimony was one of they talked about how intolerable the suffering was that they were facing. And their testimony was almost exactly the same as testimony that I and other people in Human Rights Watch will often get when we're interviewing torture victims. Um, and so it's an expression of how they would do anything to make the pain stop. And often a torture victim will sign a confession, and at that point, the torture will end. A patient with cancer pain doesn't have that option. And very often they will suffer for weeks and sometimes months with pain that is not properly treated. In fact, we've interviewed quite a few people who told us that they became suicidal. We've documented cases of people who actually tried to commit suicide because they couldn't stand the pain anymore. And so for me, that really captured kind of why this is a human rights issue. Now, of course, there are legal grounds as well. There is an internationally recognized right to health, which which grants people a right to access proper healthcare services throughout the life course. So the right to health doesn't say it's only for people who are curable or only for people with certain illnesses. It is from the day we are born until the moment we die, we have a right to health. And so what we have seen a lot in our research is that health systems and health policies focus a lot on preventive medicine, on curative medicine, on diagnosis, but not on what happens to people when they are no longer curable. And so often this is a group of patients that is almost completely neglected, forgotten by healthcare systems. And that is not consistent with the right to health, because we all have the right to access appropriate healthcare services from the moment we're born until the moment we die.
So, yeah, I think that explains very well the legal and some of the moral reasons for palliative care. As a physician, palliative care seems to me very fundamental. Um, Medicine has become very rationalized, and that's given us a lot of power to prevent and cure diseases. But medicine has become more and more split up into specialties focused on specific organs like cardiology and nephrology, or specific types of diseases like infectious disease or oncology, or specific technical skills like surgery or pathology. But there hasn't been a focus on patients, on persons, or even on families, has been lost largely. And I think palliative care is a sort of corrective for medicine that has become overly specialized, focusing on organs and sometimes even on molecules. What's most fundamental about palliative care is, for me, what's most fundamental about medicine, and that is responding to suffering. That's in the WHO definition of palliative care. It's a response to suffering that tries to prevent it and to relieve it. And it focuses on people, because on everyone suffers at some point in their life. Palliative care not only decreases suffering, but by doing so, it can improve functional status. So patients, when their pain is relieved, are more able to participate in family and social life, sometimes able to work, able to take care of themselves. It improves their quality of life. Palliative care, particularly, and we'll talk about models in a moment, but palliative care that's offered locally in communities and in the home also provides financial risk protection for families. So many patients and patients' families are impoverished, paying for medical care particularly at hospitals, which also takes patients and their caregivers away from the home and may not be particularly beneficial, particularly for patients at the end of life. So palliative care provided locally can provide financial risk protection for families and, as we'll discuss in a moment, can save money for healthcare systems. So maybe I should then proceed on to talking about where palliative care should be provided and by whom. And it's very well accepted, and WHO is very strongly supporting the idea that palliative care should be available at all levels of healthcare systems. Beginning at the grassroots level, palliative care needs to be integrated into primary care. Most patients who are near the end of life are at home and want to be at home. And one of the problems, financial difficulties of patients at the end of life, both for patients and for the healthcare system, is that when symptoms get out of control, when patients are in pain or having any kind of symptom, they need to go back to referral hospitals, often far away, if care isn't available in the community. And referral hospitals tend to be focused mostly on cure or on treating diseases when there's no better or no more treatment for a disease, be it cancer or heart failure or end-stage liver disease or kidney disease or neurologic disease, whatever it is. Patients often go home with no further care. So palliative care needs to be provided at home, and in many countries, the best model for providing this care is community health workers who are from the patient's community, who can visit every day. They don't require a lot of training, just the ability to recognize when pain or other symptoms are not well controlled, or when there's no food in the house, or when the children don't have tuition to go to school, and to report that. They can be supervised by nurses or doctors at community health centers with basic training in palliative care, maybe 3 to 5 days of basic training, so that many problems, many symptoms that get out of control at home can then be controlled in the home. Adjustments can be made in the regimen. The next level after home care and community health center is district hospitals and provincial hospitals and referral hospitals. And at each level, there can be a few clinicians, nurses, and doctors with a little bit more training in palliative care. Ideally, in the long term, in a low and middle income country, there would be specialists in palliative medicine at the highest level, who would be the teachers for people at lower levels. But task shifting can definitely be done in palliative care. Palliative care is often not complicated, and it can and should be provided at community level. Did you want to comment as well?
Yeah, I think for me that one of the key things under human rights standards is that healthcare services need to be accessible. And accessibility for people who are at the end of life and who often cannot travel long distances anymore means that the services have to be accessible, available in their community. A number of years ago, we profiled a woman in her 70s in Mexico who was suffering from pancreatic cancer. And we traveled with her from her home in a state a few hours from Mexico City to the National Cancer Center. She was no longer getting curative treatment. She was only getting palliative care, but there was no hospital anywhere in her state that provided palliative care. So her only option to get morphine an inexpensive medication that she was administering herself, or her kids were administering it to her, she had to travel on multiple buses, standing in a bus, a woman with pancreatic cancer, for hours in order to get to the hospital, then at the hospital meet with the doctors, get her medications, and then a 4-hour trip back home. It's not, I mean, when we met with this woman, she was still physically strong enough to do this, but that doesn't last. And so at some point, she will have no longer been able to make that trip, which would mean that then her relatives would have to travel without her, which would mean that the physicians would have to make adjustments to, her, to the dosage, prescribe other medications based on report from family members. And so you end up in this situation where the clinical care suffers, or the patients have to go through these horrendous kind of trips in order to access very basic care that could be provided in the community itself as well. And so that's, to me, that is kind of really demonstrates why it's so important that this kind of service be available at the local level rather than only in tertiary care centers.
And I would just add, coming to the point I made earlier, that there is now evidence that palliative care, when well integrated into health systems at all levels and includes home care, this can save money for healthcare systems. Now, this data is only available from high-income countries and a few high-middle-income countries, such as South Africa and Romania. But it appears that when there's an investment in palliative care, enough to establish or to integrate a palliative care network into existing healthcare systems that includes home care with community health workers and basic palliative care at community level and more sophisticated palliative care in hospitals with good communication between all levels. This can help to obviate the need for readmission to the hospital near the end of life. Patients don't have to go back to the hospital like Diederik just described. Long trips that are very difficult and painful and expensive, and someone needs to accompany the patient. Often they can get the care they need in their home. So fewer admissions to overcrowded, expensive hospitals, and patients who are already in the hospital can stay for a shorter period. The length of stay can be shorter because patients aren't afraid to go home. They know that there's a safety net, that they'll be able to get care in the community. So there's now copious evidence from higher income countries that this can save money for healthcare systems. Therefore, ministers of health don't have to decide, do we implement palliative care or do we fund more vaccines for children or maternal child health or tuberculosis? There can be more money for other programs. So I think there's a very important moral and medical argument for palliative care. There's a legal argument by international agreements, and there's even a financial argument. So I don't know what more reason there needs to be. This needs to be available to everyone, everywhere, including the rural poor.